All right, guys. Good morning. Thank you very much for connecting. Let me start the presentation. Okay. I hope you can hear me well. In case, please, Daria, let me know. Just send me a message. So that's a very basic presentation on some central nervous system infections and inflammation in children. And I will show you, as always, I do some case-based presentation based on the mistakes I do every day, cases we see, and we discussed. Um, Basically, what I would like to do is to show you some pattern recognition about infection. And this is the outline of the summary of the lecture. So I will show you viral infection and bacterial infection. Actually, will show you how the abscesses look like. There are some differential diagnosis that we can do using advanced techniques with abscesses, but I will just touch base that, and then I have another lecture only on abscesses and differential diagnosis, but just to give you an idea, especially in children, because it's very, very important to recognize biogenic infection. And then I will introduce you some concept about what's new in terms of demyelination disorders in children. That is very, very important. So basically, what's different between children and adults, that whose main demyelination disorder is basically multiple sclerosis. So let's start with the viral infection, and that's a very, very important uh, pattern that you need to recognize. So this is an MR. You can see the T2 and diffusion in a very young neonate. So basically, in a neonate, 9-day-old, and the age is very important when you see this pattern. And this is a little girl who presented with fever, irritability, and seizure, and all the tests were normal. This is always important to take in mind. So sometimes the test looking for infection in viral infection can be normal. Okay. Now, the problem is that what you probably know, and I will show you a lot of cases in a bit, is that the viruses can have a predilection for the gray matter. Well, not all of them. There are some viruses that have predilection for the white matter, and they typically show these large areas of white matter abnormalities with diffusion restriction. Why is important the diffusion? Because as I showed you last time when I spoke about the development of the brain of the neonate is not myelinated. So you cannot use really the T2 because the white matter is already physiologically full of water. So you will not see the edema that you will see in an adult so easily in a child. However, you can see here that the fusion is very positive, of course, but the interesting thing is that the posterior limb of the internal capsule are involved, and you can see that the signal is bright, apart from these patchy areas of normal signal also in the tunnel, but the signal is bright in the posterior limb of the internal capsule. And I told you last time that the plic should be myelinated at birth, so this is an abnormal signal. But as you can see, DWI is much more striking, and the distribution is along the of these areas of abnormalities is along the deep medullary veins territories with some what we call like prevalerian degeneration of the fibers of the forceps major, prevalerian degeneration, meaning that is basically a degeneration of the along the fibers when the territory involved is this. So basically the degeneration follows the normal fibers anatomy downwards. So what is that? This is a viral infection, of course, because we are speaking about viral infection. And this is a human paracovirus infection. There are some other viruses that give you these findings, but the important thing is the paracovirus is the one who has been described the most. But the important thing is that to write in the report, this is a white matter distribution in neonate suggestive of viral infections such as paracovirus. It's not the only one, but look, in T2 has how it's very difficult to see. You can have some areas of hypo intensity along the deep medullary vein distribution, almost look like this deep medullary vein engorgement pattern with punctate white matter lesion I showed you last time, because the areas that are involved are the same. But the diffusion is striking, is much wider, and you have this tear-like abnormality. So they shaped like a tear in the face, at least as I like to describe. And then it's important because over time you have PVL, periventricular leukomalacia. So PVL is not only something that you can have in prenatal, in preterm, sorry, neonates, but is just a descriptive term of a leukomalacia involving the white matter in the ventricle. So remember this pattern for Paracovirus, very, very important. This is a paper that you can download. We are recording this lecture, so all the reference, there are at least 3 papers, very important, that I would like to suggest. So this is one of them. Now, second case, history of abdominal pain, fever, and neurological signs. So again, the fever is a trigger for an infection. In this case, you see that there is gray matter distribution. Now, when you see these areas of abnormal signal in the gray matter, in a young child with a fever, you think of a viral infection. One thing that is very important is that when you have symmetrical lesion in the basal ganglia, you think of metabolic neurogenetic disorder like mitochondrial disorder, not only mitochondria, but this is the best example. When the lesions are bilateral but asymmetric, think more about infection, because of course this is not a genetic problem involving all the body. Anyway, in this case, I show you the MRA. The vessels are completely normal, and this is very important. So you have an infection in a child hitting the gray matter, asymmetric, bilateral asymmetric distribution, normal vein. These are the characteristics of your report, because I try to make it practical as much as I can. And this is Epstein-Barr virus encephalitis, typical distribution in the basal ganglia. Let's see this other thing. Again, remember, you can have a bit of an answer, you can have a bit of patchy restriction, and sometimes also hemorrhagic degeneration. But it's not all restricting, it's not all enhancing, it's not an ischemia. Apart from this paracovirus that I show you, where the diffusion is much more florid. Okay, in this case, we have again a child older in this case with headache, lethargy, so encephalopathic, and you have someone say there is no sound, but Daria, you can hear me, right? I hope so. Yes, so I think it's the problem is in your computer. Okay. Basically, in this case, note the distribution. Again, bilateral, again, asymmetric. So in this case, think of an infection, and there is a bit of patchy restriction. This is completely okay for a viral infection, but there is no basal ganglia involvement. In this case, and again, this is what the book says, but in the real practice, sometimes in the daily clinical practice, sometimes there is an overlap. But in this case, the sparing of basal ganglia, the involvement of the limbic insular system, and the mesiofrontal area are more likely to be in keeping with herpes simplex encephalitis, that also will give you hemorrhagic degeneration. So if you Google herpes simplex encephalitis MRI, you will have a lot of hemorrhagic degeneration as well. So these are the 3 main patterns: paracovirus, white matter, Epstein-Barr, basal ganglia, encephalitis, herpetic encephalitis from herpes simplex, sparing of the basal ganglia, limbic system, mesiofrontal region. Now look at this. This is very, very important again as a pattern recognition. There's plenty of patterns describing viruses and other infections, but I'm just giving you the main important findings in terms of pattern recognition. 5 years old May, recurrent TIA, transitory ischemic attack, right side semiology, You see this area of hypodensity on CT? Well, it's easy. That's a stroke. Okay, fine. And this is confirmed on DWI. That's a stroke. Okay. Now, a stroke in the non-neonatal period is kind of a problem for us. Of course, it's possible. And in this case, this was a stroke, and this was confirmed on MRA. Sorry for the low quality in this case. Of course, you have several territories of hyperintensity in flare. So diffusion positive, flare positive, stenosis of the middle cerebral artery. On the same side, we have the diagnosis. But please keep thinking and keep thinking out of the box. You ask the parents, and the child had varicella 1 month before the symptom. So not immediately before the symptom, but a few weeks before the symptom. And this child had varicella zoster positivity, so antibodies for varicella zoster. So this is a typical vasculitis post-varicella zoster. And this is very important to know that one of the main causes of stroke in children is post-varicella. Because of course they do not have atherosclerosis, while in adults we have a lot of strokes for genetic causes. We have moya, we can have vertebral dissection after a trauma, but remember varicella zoster. So you give a diagnosis, and this MRI picture can recover over time. So it can go better. And the important thing is that then we do not expect you are not looking for another cause for this stroke, and you have a diagnosis, you can close the case. So it's very important to ask whether or not there was a history of varicella a few weeks before. So a summary of the central nervous system involvement for the herpes virus family is that the Epstein-Barr mainly involves the deep gray matter structure. You can have a non-specific involvement of the cortex and also hemispheric white matter. And you can have the Epstein-Barr also cause optic neuritis. It's not so frequent, but it's possible. And this is good for the differential with demyelinating disorder. I will tell you in a while. And then remember herpes simplex, limbic system. Again, all the viruses tend to have an asymmetric bilateral involvement. You can have hemorrhagic degeneration, and typically the deep gray matter structure are spared. Finally, vasculitis and brain ischemias are typical post-varicella evolution. Now, let's start with another case. We are always in the realm of viral encephalitis. So we have a 8-month male with history of pharyngitis, very, very important. So we have a history of infection, but the child is acute encephalopathic and has also right upper limb weakness. So signs that can be related to cord involvement. So you can have here patchy, you will see here that there are patchy areas of enhancement in the cerebellum. So in this context, you think of cerebellitis, maybe in the brain, but what catch your attention is a pattern that we didn't see before with parechovirus and with the herpes viridia family, and is in an involvement of the posterior aspect of the brainstem and the anterior aspect of the cord. So you have the anterior column of the spinal cord involved, posterior brainstem, as you can see here at the level of medulla oblongata, and there is diffusion restriction. Now, you may say, but this is symmetric, so it has to be something like an infarction. Actually, looks symmetric on DWI, but look at the T2. Again, patchy, bilateral, but slightly asymmetric, okay? So what is that? When you see something like that, again, you have some differential, and I will show you before some inflammatory differential, but you must think of enteroviral encephalomyelitis. Typically, enterovirus encephalomyelitis can hit the posterior portion of the brainstem, substantia nigra, dentate nucleus, so cerebellum as well, and the anterior horns of the spinal cord. And of course, you can have brain and cerebellum involvement, but these are some areas that characteristically are involved in this family of viruses. So think of this, and again, bilateral, yes, slightly asymmetric, definitely asymmetric in the core. So again, you may have a certain amount of symmetry because there are very small structure, but there is always, or most of the time, you may be able to find a slight asymmetry. And so this is enterovirus. This is another paper you really need to have as a pattern recognition. So if you have a doubt, you can come back to the literature. And another case, also very important. Here you have enhancement. Hyperintensity in anterior column, only on one side here, not sure, but also you have enhancement of the cauda equina roots, enhancement of the anterior roots of the cauda equina. This is a male, 22 months, with ascending paralysis and progressive loss of motor skill in legs. When you have an ascending paralysis, and enhancement of the cauda equina roots, you think Guillain-Barré syndrome, of course. And remember, the only way you can do Guillain-Barré syndrome diagnosis on MR is giving contrast and looking in axial and coronal to the cauda equina root. So in this case, you need contrast. But this is not a Guillain-Barré. This is another enterovirus. In this case, it was an enterovirus 71. But the point is that enteroviruses can give you lesion in the spinal cord, but also enhancement of the cauda equina roots. The difference with Guillain-Barré is Guillain-Barré will not give you typically abnormalities in the spinal cord, in the brainstem, and in the brain, but only this enhancement. Okay, so this is a companion case. This is a Guillain-Barré. You see the enhancement of the anterior cauda equina roots is very similar, but in this case we add the involvement of the spinal cord. So that's very, very important. Remember this. And again, there are some paper on AGNR. Sorry, I forgot to put it here, but I can send it afterwards while you do maybe question at the end. I can find out the paper and send it to you. Now, other infection, very, very important. Child with jaundice, hepatomegaly, splenomegaly, microcephaly, and hearing loss. You have this, hepatomegaly, splenomegaly, microcephaly, hearing loss. You don't need the MR. You have already the diagnosis. But here you have also prominent subcortical cyst in the temporal lobe, very typical, white matter abnormalities. You may have some calcification, but this is typical of congenital CMV. Look at this case. 8 months falling motor disorder, microcephaly again. Look at this. You remember I showed you in the pattern recognition lecture on neurogenetic disorder, I show you all these temporal cyst or cystic-like structure that can be found in Aicardi-Gutierrez, in MLD, and in cytomegalovirus. So in this case, this is another example of cytomegalovirus. But the appearances of the brain are very different from the previous one. So in this case, you have bilateral diffuse against slightly asymmetric polymicrogyria. White matter changes before you didn't have polymicrogyria. This is again a congenital cytomegalovirus. What's the difference? The difference is that in this case, the infection happened before in the pregnancy. So while the brain was forming, and this is why you had a lot of malformation in the form of polymicrogyria because of abnormal organization of the cortex, which is not present before because probably in this case was later on in the pregnancy. So what is important is that in the torch or torch-like infection, you have the age of the fetus at the time of the insult is more important than the nature of insult. Another important thing is, torch is toxoplasma, rubella, cytomegalovirus, herpes, and then you have also syphilis. But another important thing is intracranial calcification, very, very common. Now, you can have periventricular calcification more frequent in infection, while deep gray matter calcification, so calcifications in the basal ganglia, are more common in Aicardi-Gutierrez and other neurogenetic disorders. But of course, again, I'm giving you the more frequent patterns that you can recognize. This is not gospel, but this is very interesting. This is from the Barkovich-Raybould book, and all of them, apart from the herpes simplex, they have calcification intracranially, slight differences that I will show you. But first of all, let me show you this very serious congenital infection. Again, calcification, they are not periventricular, but in the basal ganglia and in the subcortical region. But look how microcephalic is. This is a courtesy of a friend of mine, Adriano Hazin, that published these cases in New England Journal of Medicine. So Google his name and New England Journal of Medicine, you will find a beautiful editorial. But look at this tremendous microcephaly. We don't have the MR, we don't need it, but look at the skull, and this is Zika virus congenital infection. So remember again, this is a flavivirus, it's very aggressive, but again, hit very early in the pregnancy, created this terrible microcephaly with a lot of calcification that are typical of the congenital infection. Congenital toxoplasmosis is slightly different. You have calcification, as you can see, but typically it presents with dilatation of the ventricles. Now, I will probably have a lecture on hydrocephalus because I've been asked to speak about hydrocephalus for the next European course of pediatric neuroradiology, so I'm studying now. So if I will have it ready, I will give it to you if you want. But it's important to consider that in this case there is an hydrocephalus, so the system is under pressure, but there is also combination with the loss of white matter. So you can have combination of ex vacuo dilatation of the ventricles with an obstructive, and this is typically happening in congenital toxoplasmosis with this enlargement of the ventricles, particularly the posterior temporal aspect of the ventricle, okay? But again, you can have toxoplasmosis afterwards. Acquired toxoplasmosis show this typical target sign, and typically no restriction diffusion, important for the differential diagnosis with pyogenic abscesses that I will show you before, and low perfusion. So this concentric target sign typical of toxoplasmosis, but this is acquired toxoplasmosis. So again, I would like to stress that in this kind of infection, the time of the insult is more important than the agent. So this is the first part of this lecture, and this is Ravello from Amalfi Coast, where you can listen. Not now because everything is shut down because COVID, but you know this is where I'm from, somewhere here, and so come visit. Second part, cerebritis and brain abscesses in children. So first of all, this is really very basic semiology, radiological semiology, but you need to know to understand why these lesions are in specific part of the brain. You need to know how these bacteria enter the brain. Okay. Hematogenous spread, most common. So distal infection going into the blood, reaching the brain. Contagion infection, automastoiditis, sinusitis, meningitis, very, very, very important for the associated complication. Direct trauma implantation and associated with cardiopulmonary malformation. These are rare causes. So where? Supratemporal region in each region, typically in the subcortical white matter. Why? Because it's very vascularized. Same for the basal ganglia. Although these are more rare, but common in specific agents. For instance, infection by streptococcal infection can give you typically basal ganglia abscess. So you can use location, first of all, to understand the pathophysiology. More vascularized area are more likely to be involved, and from hematogenic spread, but also remember the location can give you um, um, suggestion related to the pathogenic agent involved. And then you can have location in the posterior fossa. Very important because you need to look at the mastoiditis. I showed you an example in the emergency lecture last time. and multiple location, think of immunodepression. In neonatal age, you can also have multiple location in a periventricular, multiple lesions in a periventricular location, because the vascularization in the periventricular area is still very prominent in the neonates. And I show you the Parechovirus. Of course, it's not a bacteria, but the distribution is typically periventricular. But also remember, the multiple lesion is due to the fact that the immunitary system in the neonate is really immature, and this explains some evolution over time, some different appearance for the radiologist that I will show you in a bit. So remember, what we see in the pyogenic infection is the combination between the immunitary system and the infection, and because in the neonates, the immunitary system is not so well developed, we will have different evolution in comparison to older children. Now, what are the clinical features? Non-specific. Of course, you have fever. Of course, if you have an abscess, which is a localized abnormality, you will have focal neurological signs. To understand what we see on imaging, we need to understand what we have on pathology. So we have first stages of cerebritis that then evolves in abscess. The difference between cerebritis and abscess is the reaction of the immunitary system that in the later stage forms a capsule around the area of inflammation. So this is from the Osborne Brain book from 2014, where there are a lot of pathological images, and you can see all these polymorphonucleates in the brain, and these are some ill-defined areas of cerebritis. How they look like? Well, they look like that. There is a lot of edema, patchy area of enhancement, and hypointensity in T2. These areas actually represent the ongoing immunitary reaction, not yet organized as will be in a subsequent abscess. In a subsequent abscess, we have the capsule formation, and that's very important because we can really compare what we see on imaging with what the pathologist sees on microscope. So the abscess takes in a non-neonatal child almost 10 days and is formed by 5 layers. We have a necrotic center and then a capsule that is made of granulation tissue, lymphocyte, and fibrous tissue. This is immunitary reaction. And then we have surrounding edema and gliosis, okay? And this is a screenshot of pathology, and you have that this part here is the necrosis, okay? It's very fluid. This very packed and dense area is the capsule, which is very active and will show you all the characteristic on imaging of the active inflammation. And then we have this edema and gliosis. When we see on images, and this is normal brain, we will see exactly the same thing. So let's start with normal T2 and T1, and for CT is the same. We have the central necrosis that is fluid, so T2 hyper, T2 hypo. Okay? The T2 signal can be variable, so it's not, again, that if you don't see homogeneous T2 signal, you think of something weird. There can be, of course, a variability. And then we have the external capsule I showed you before in the pathological specimen, that is T2 hypointense, T1 hyperintense. The surrounding edema is just edema, so hyperintense in T2 and hypointense in T1, so water, and the external capsule shows enhancement. So this is what we see. The core in the center, fluid, T2 hyper, T1 hypo. And then you have the capsule here that is T2 hypo and shows enhancement, and then surrounding edema that you can basically see only in T2 that is more sensitive to water. But in neonates, actually something a bit different happened because first of all, the infection is slightly different. We have gram negative. They can be complication of meningitis. We have multiple periventricular white matter abnormalities that can rupture in the ventricle. They are larger and they are incomplete because the capsule that I showed you before cannot really be completed easily in a neonate that has an immunitary system which is not well developed. And this is from Susan Blazer. This is a paper on neonatal MRI. Sorry, it's not a paper, it's a book on neonatal MRI. It's quite old, but still valid, and is online from Mary Rutherford. So if you write Mary Rutherford neonatal MRI, you can download all the books for free online. And you can see how these abscesses are, they have an inconstant capsule. They are very large to the point that they shift the midline. The child unfortunately died, and they evolve quite fast. So multiple infected cavity with rim enhancement, daughter cysts here, blood pus. So it's much more confused, the pattern, the radiological pattern. Why? Because we have much more incomplete, a much less effective reaction of the immunitary system. And this is a case from the Barkovich book. I had some recent cases from Gosh. I had no time to put it in the presentation, so I'm using the literature in this case. But you see, here you have this patchy area of restriction, a bit of hemorrhages, again, patchy, and then a bit of enhancement, quite incomplete, okay? Mild mass effect on the midline. And then wait a bit, just 5 days later, I told you before, normally an abscess will need 10 days. Diffusion restriction, more prominent, big capsule, but you see they are incomplete here. This is, you know, more or less complete, but there are still areas of incomplete enhancement and massive shift, midline shift. Why this is important? Because this is a surgical emergency. You need to recognize a pyogenic abscess in neonate as soon as possible. Now, how you confirm that this is a pyogenic abscess? Like the cholesteatoma talk that I did some times ago, here is exactly the same. You need diffusion. Diffusion restriction is typical of pus. And if you remember this slide about diffusion restriction I showed you in the first lecture on general concept on MRI, you will remember that you can have diffusion restriction in infarction, in very aggressive brain tumor, embryonal tumor, and also in pus, because in the pus there is no water. Okay, and this is important because allows you also not only to diagnose the central core of the abscess, so you are sure this is a pyogenic abscess, but also the presence of pus in the ventricle. So this is a pyogenic ventriculitis with a fluid level, but the inferior part that is denser in T2 also shows diffusion restriction. So this is a ventriculitis, very, very important. And why is also important, the pus? Because this is a child from Gosh, from my hospital, with an abscess, okay? So you have the edema, T2 hyperintense, and then the capsule here, T2 hypointense, a bit of heterogeneity inside, but most of the core is fluid in T2 and shows restriction. So we told them this is a pyogenic abscess, clinic was consistent, and basically what we decided to do is basically they decided to treat the child, okay? When they decided to treat the child, they did a follow-up, of course, and few days down the line, the size of the abscess was the same, if not even a bit bigger. But look at the content is changing, and look at the diffusion restriction is gone. So the bottom line is that you can use diffusion restriction not only for diagnosis, but also to check the the treatment in the follow-up scan. This is very, very important. You have mastoiditis, abscess with the rim enhancement. In the middle, there is the sinus. So one complication of mastoiditis is a cerebellar abscess. So when you see a cerebellar abscess, look at the mastoid. But one complication of the mastoiditis in association or not with cerebellar abscess is the presence of venous sinus thrombosis. So if you have a mastoiditis, look at the venous sinus, not only at the cerebellum. So remember that these three pathological entities are interconnected. And this is also an emergency, so you need to recognize. Now, The final 20 minutes, I hope this is clear, but please, if you have any question afterwards, I'm very happy to come back to the slides because I know that there are a lot of information. It's quite packed lecture, and this is an introductory lecture. But this is my hospital, Great Ormond Street, before and after. So it's a very, very old hospital in London. Old in the sense that it opened times ago, not that it's so now it's quite modern, as you can see. And now I would like to speak to you about inflammation, and in particular, demyelination disorder. Now, demyelination disorder are divided in 3 groups. We have multiple sclerosis. Normally, we have multiple sclerosis in young adults, as you know, but we can have also in children. And then you have neuromyelitic optical spectrum disorder, NMOSD, and you have the ADEM with all this multiphasic ADEM kind of evolution that I will speak to you about. So remember, multiple sclerosis, neuromyelitic opticals, and ADEM. 3 big demyelinating disorders. Now, why is it important to do the right diagnosis? Because the earlier you treat the children, the better they go in terms of outcome. So you need to do the right diagnosis or to guide the neurologist toward the right diagnosis. Now, case 1, 5-year-old girl, 2002, right side prolonged seizure, no fever, important thing. But they found 18 mononuclear cell and protein elevated in the lumbar puncture, so CSF, EG non-specific, but generalized slowing. Blood was normal. They say clinically this is an encephalitis. They do antibiotics. And I need to thank for this information part Dr. Hakoen and Dr. Mankad and Dr. Hemingway. They are leading on that part, so they gave me a lot of cases. This was the MRI 6 weeks later. So 6 weeks later, antibiotics of course they did not work. The child developed encephalopathy. Oligochronal bar negative, but what you see on MRI are these large asymmetric bilateral lesion involving the white matter. This is typical of ADEM. So the revised diagnosis ADEM that stands for acute disseminated encephalomyelitis. Remember, we can suggest ADEM-like pattern on images, but this is a clinical diagnosis. We treated the child with cortisone and she was better. So what is the definition? A first polyfocal presumed inflammatory clinical central nervous system event that must include encephalopathy, that's very important. Encephalopathy not explained by fever, because of course if you have fever you can have encephalopathy. Frequently it follows infection, and brain MRI is abnormal in the acute phase and acute early subacute phase. So in the first 3 months we have abnormality, and then it goes away. What we see in MRI is exactly what I described before: poorly demarcated large lesion, and they can also involve the deep gray matter. Okay, so there can be an overlap with the viral infection. But the important thing is this is one event only. This does not include so-called recurrent ADEM, and this is a clinical diagnosis. The outcome in ADEM is very, very good because most of these people, and that's very important, focus on that because there are new stuff. So when this is 2011, okay, 7% recover, 1%, 0.1% can die, 5% experience a second ADEM attack. So they called before multiphasic DEM. So it's not acute anymore, it's MDEM, so multiphasic. 20% becomes multiple sclerosis because they fit the criteria of multiple sclerosis. So you see that there is a bit of confusion. So when you have just an event of ADEM, you are fine because the child is better. You label this as a clinical radiological diagnosis ADEM, that's fine. But when the child keeps being ill, you can either diagnose a multiphasic ADEM or an MS. And I will show you this case that was given to me by Dr. Hako and Dr. Mankad. September 2002, patchy abnormality in the white matter. Okay, you can see here. You can see here the child was encephalopathic, ADEM. Okay, fine. And then 2004, to 2 years down the line, lesion in the middle cerebellar peduncle, okay, and lesion in the basal ganglia and in the white matter. Okay, this has to be something recurrent. So we keep following up. The lesions are now better in the middle cerebellar peduncle, a bit better in the white matter, so it's improving. We don't know what is that, but we call it multiphasic edema, MDEM, okay, because it fits the definition that I will show you in a while. And then we keep following up. The child is very, very bad, at least radiologically. So with lesion popping up on the other side, more lesion in the basal ganglia, and so on and so on. And then the child developed finally atrophy. So we have 7 years of this evolution of this lesion that look like edema, but are they keep popping up here and there. And at some point, the child developed atrophy. So what is that? Let's look at the definition of multiphasic edema. So this is the definition of multiphasic edema. So a new event of edema 3 months or more after the initial event that can be associated with the new emerge of prior clinical and MRI findings. So we have basically a new edema with encephalopathy and new abnormalities in MRI, okay? So why some of them, the recurrent edema, were classified as multiple sclerosis? Well, let's look at relapsing remitting multiple sclerosis, and they say this is an edema followed 3 months later by non-encephalopathic clinical event with new lesion. So if there is encephalopathic, we call it multiphasic edema before. If was not encephalopathic, we call it relapsing remitting MS. And clearly there is confusion, and clearly we were wrong. So in this case, this was a clinical diagnosis of edema 2013. Again, look at the evolution, lesion less prominent here on the right, more prominent here on the left, and then even more prominent, and then less prominent again, more prominent again, and so on and so on. And then in 2015, develop enhancement, start to develop large white matter lesion, not only localized in the posterior fossa. This is a recurrent edema. If you want to understand what recurrent edema is, you need to read this paper. This is beautiful paper from Yael Hacohen and Shelley Hemingway from our group. And she studied a lot the relapsing acquired demyelinating syndromes, and all of them. And she figured out that children with multiple sclerosis and aquaporin actually aquaporin neuromelodic optical spectrum disorder actually show feature typical of the adult case on radiology, very similar. The edema looks like something different, and MOG positive antibody were found in all the children with relapsing remitting edemas. Can be a bit confusing. I will try to be a bit more clear in the next slide. Look at that. MS children, neuromelodic optic spectrum disorder. So this is a clinical radiological diagnosis of children with inflammation of the optic nerve, so optic neuritis plus cord involvement, and then multiphasic edema and isolated optic neuritis. So MS and NMOSD, edema multiphasic, and isolated optic neuritis. All the multiphasic edema had MOG antibodies positive. Some of the isolated optic neuritis have MOG antibodies positive, and some of the neuromelodic optical spectrum disorder, actually half of them have positivity to MOG antibodies. So we don't have anymore only the unknown etiopathogenesis of multiple sclerosis, which is a clinical radiological diagnosis and laboratoristic diagnosis. We don't have only the edema anymore, that is an isolated, again, presumed inflammation that finishes after 3 months. And we don't have only the neuromelodic optica due to these antibodies against aquaporin 4. We have a new entity that is due to antibodies against the MOG which is a protein that is in the oligodendrocyte. Okay, so what am I saying? That MRI characteristic of MOG antibodies, they can have extensive transverse myelitis, so basically extensive involvement of the cord, and optic neuritis. So they can look like neuromyelitis optica, but they can also look like ADEM with a particularly predisposition to develop lesion in the posterior fossa and the middle cerebellar peduncle. So you can have something that looks like ADEM, that looks like neuromyelitic optica spectrum disorder, okay, or that have both of them, an ADEM plus spinal involvement plus optic neuritis. In all of these cases, you need to test the MOG antibodies if you can, or just give steroid, basically, if you cannot test them. Okay, so this is a new entity. Remember, it's a new, relatively new inflammation disorder that is called MOG antibody positive encephalomyelitis, and radiologically can look like neuromyelitic optica or ADEM, recurrent ADEM action. And this is actually what they proposed in this paper. So you have a first episode of central nervous system demyelination. You do MRI brain and spinal cord. You see something that looks like multiple sclerosis, so the Dawson finger, blah, blah, blah. Yes, fits the criteria, you call it multiple sclerosis. If it looks like a neuromyelitic optica spectrum disorder, so large involvement of the spinal cord, extensive involvement of the spinal cord, optic neuritis with some lesion in the brain, check the aquaporin 4. Positive, yes, you diagnose NMO due to aquaporin 4 antibodies. If not positive, the aquaporin 4, check MOG antibodies. So you will do the diagnosis, most of the time will be positive, of MOG antibody associated. What we do at GOSH, we test them both together. If you don't have neuromyelitic optic spectrum disorder on MR, but you have fissure of ADEM, again, check immediately MOG antibodies, because all the recurrent ADEMs reported to date will have MOG antibodies associated disease. Otherwise, you need to consider something different. So I'll show you how the MOG look like. This is how multiple sclerosis look like. Small areas of involvement in the spinal cord, those on finger, these radial areas that involve the corpus callosum. And these are the criteria that I found on Wikipedia. Radiopedia or Wikipedia is the same, I guess. So you need more than 3 lesions in the periventricular location, cortical, juxtacortical, more than one lesion, or at least 1 lesion infratentorally, spinal cord, optic nerve, and then the dissemination in time. Everyone knows that, but it's important that this appearance is different from what we see in ADEM. So we think of 2 different inflammation processes, 2 different demyelination diseases. Case 4, ascending weakness again, large extensive involvement of the spinal cord, aquaporin 4, NMO spectrum disease that can have optic neuritis, transverse myelitis. Remember, transverse myelitis is a clinical term because it refers to the clinical presentation, but you have extensive involvement of the spinal cord, and you can, and these are the diagnosis with MRI brain abnormality, then follow distribution of aquaporin 4 channel. So because this neuromyelitic optic spectrum disorder is due to antibodies against the aquaporin 4, the distribution of aquaporin 4 into the brain determines the distribution of the abnormalities into the brain and also spine. So let's see where this distribution, everything close to the ventricle. So close to the ventricle, there are a lot, of course, there is CSF, so you need aquaporin. So the distribution in the brain of the aquaporin 4 positive NMO spectrum disorder is different from the distribution of the brain in the MOG positive, okay? Or at least in part. There is an overlap, of course, but in part different. And often you have the involvement of the area postrema, but remember, everything around the ventricle can be positive. And also the involvement of the optic neuritis is different between aquaporin 4 and MOG, because it's been reported that the MOG positive antibodies um, involve more the intracornal part of the optic nerves, while the prechiasmatic part is more involved in the aquaporin. Okay, so we can use slightly different localization to appear very smart, but actually what we do here, we test both. Finally, there is this entity that is very easy. So no encephalopathy, 1 day of not using right arm, 20 minutes, 20 months female, 3-day history of dragging right legs, and 1 day of not using right arm. So focal neurology, area hypodensity, we call it ischemia, stroke, but actually this was not a stroke. This was, you see, the diffusion restriction is only peripheral. It's quite fluffy, this appearance on T2, and there is no vasculopathy demonstrated. So this is a monofocal demyelination that will go away, and this is with the cortisone, so excellent improvement. And this is the definition of first monofocal or multifocal CNS demyelinating event without encephalopathy, that then was revised, in encephalopathy absent unless due to fever. So basically, you have just one single event that um, uh, um, resolve after a while. So in a way, the definition, they overlap with ADEM and so on. But remember that we don't know the cause of most of this. This is why it's important for me to stress the aquaporin and the MOG, that are two demyelinating disorder we know the cause of. So I know that probably were a lot of information, but let me summarize the demyelinating disorder in children. MS, similar to adult, you can have brain, spine, and optic neuritis. The spine involvement is small segment of the spine, typical dozen fingers on the brain here. So this radial abnormalities along the corpus callosum. Remember, if you have a demyelinating disorder, do the sagittal flare, very useful, or a 3D flare. ADEM, one episode less than 3 months, brain plus encephalopathy with this large lesion of white matter in the brain, but can also involve the basal ganglia. And remember, all the recurrent ADEM are MOG positive. NMO aquaporin 4, you have a large tract of the spinal cord involved. You have optic neuritis, in particularly the prechiasmatic part, and you have involvement of the brain of the brain areas rich of aquaporin 4. The MOG antibody looks like either an ADEM, recurrent ADEM, or an NMO radiological with some differences, but it has the typical involvement of the posterior fossa, and typically there is this involvement of the intra orbital part of the optic nerve. Okay. Finally, CIS, so an isolated single demyelinating event without encephalopathy. Okay. I have some chat here. This is just one thing I would like to show you. This is the paper that you can download for free from the Brazilian group in São Paulo. Brazilians have very amazing school of neuroradiology, and a lot of professionals, and this you can download, and it show you the spectrum, the neurooptic melody spectrum disorder with the MRI findings, and also the differential diagnosis. I think it's very important to have this paper together with the one from Hako in neurology. So in conclusion, brain infection in children start from the radiological parter. CNS inflammation, let the clinician guide you, and be aware of the new entities like MOG. Children are not small adults, and neonates are not very small children. And this is Naples, this is San Carlo Theater. Sorry, I'm trying to promote you visiting south of Italy. And now, if you want, you can just chat some question if you want. I can let me check here. Okay, so if Daria Godwin they want to say something, please. And if someone has any question, please you can just chat it to me. Okay, let's see the question. Chat. Okay, nothing. Hi, Godwin. Do you want to say anything?
Yes, I want to say thank you very much. Very, very beautiful lecture. Very extensive. I'm sure my residents will really love this. It's a lot of material, and I'm looking. I ask you a question. Is it possible for us, maybe in the next couple of weeks, to have a neuro-COVID lecture on COVID-19, something to do, maybe like in the next 2 weeks or so?
Actually, we did a lecture. We did present some cases yesterday. I'm very sorry, I forgot to include you, but I will definitely. I can ask my colleague who is neurologist Marios to do a lecture showing the cases that we have. The bottom line, we have a lot of because the COVID is not a direct infection; it's more a cytokine storms. We have a lot of inflammation, like cytotoxic response to the brain. In particular, we had 4 cases with splenial restriction. Some other centers, they have ANEC, so acute necrotizing encephalitis, like the one from influenza. So this is something to keep in mind. So this is a reaction of the immunitary system rather than a direct infection. But I will ask Marius to give you a lecture as soon as I can. Okay.
Thank you. That was like, thank you very much.
Let's say the capsule around the abscess in immunosuppressive patients.
Yeah. So basically, the capsule is incomplete when present, and because it's incomplete, it's like the neonate. It tends to evolve very fast in time. So this is why you need to use a lot of diffusion and use the clinical setting, because if you don't pick up a cerebritis in the initial phase in the neonate or in an immunodepressed patient, you will have a mess. Really, midline shift, the child can die. So that's very, very important. This is why I showed you this. The neonate is not really a small child. It's different immunitary system, and it's different the way you need to react to that.
Okay. Thank you.
Okay, thank you guys, and have a nice day. And I will keep you in the loop for all the presentation, also in the neuroscience meeting that we do at GOSH. And remember, this Saturday, the American Society of Pediatric Neuroradiology organized a lecture on complication of ventricular shunt, so very practical lecture from Michelle Silvera. So I will share the with Godwin and Daria the link as soon as I have, or you can just send an email to the Twitter account of the American Society of Pediatric Neuroradiology. Okay, thank you guys, and have a nice day.
Bye.